And joining us now on the debate, Dr. Rob Gordon. He is an orthopedic surgeon and superintendent of the Don Mills Surgical Unit. Jeffrey Wetherill, president and CEO of West Champlain Healthy Community Corporation in Pembroke, Ontario. Susan Fenton, vice president of government and stakeholder relations with Pharma Trust. Shirley Sharkey, president and CEO of St. Elizabeth Healthcare. And Dr. David Greatzer, senior fellow at the Manhattan Institute and the author of The Cure: How Capitalism Can Save American Healthcare. It's good of all of you to join us tonight. Thanks so much. Some of you drove from quite a distance to be here, so we're really quite grateful. I want to start by putting up this graph, because if you want to see what everybody at Queen's Park is afraid of, it's this graph. The line on this graph. Projected healthcare spending. Here's 2010, where we are right now, and as they project forward over the next 30 years, that line just goes right up to heaven. And as we suggested in the opening, we're spending about 46 cents of every dollar today on healthcare, trending towards 70, and the government wants to figure out how to bring that line, curve it down a little bit. David, to you first. General inflation in our economy runs about 1 or 2%, has for many, many years. Healthcare inflation seems to go at 6, 7, 8, 9. How come?
Well, I think part of the answer to that question, part of the answer is that medicine is better than ever. Death by cardiovascular disease has dropped by 2/3 in the last 60 years. Polio is confined to the history books. Illnesses that were once a death sentence, like childhood leukemia, are eminently treatable. But, I also think it has to do with the way we organize healthcare, particularly in Canada, and the way we think about healthcare in Canada.
Just follow up on that a little bit. How do you mean?
Well, I think we've got a system that's really rising out of the best thinking of the 1940s and the National Health Service.
That's not a compliment, I gather.
It's not necessarily criticism, but one has to take it within context. This is an era when penicillin was considered cutting edge and experimental, when we talk about healthcare insurance, what we're talking about is disability. And pharmaceuticals really are unheard of. Hospital costs are really about laundry and taking care of people. The world has been transformed. As I've mentioned just a moment ago, medicine is so terribly different. And yet our model for healthcare really hasn't much evolved.
Okay, we're going to get into some of this tonight. Jeffrey, let me bring you in at this point. Every public opinion survey says people care a lot about healthcare in this country. They're happy to have it be our #1 priority, and they're happy to have us spend a lot of money on it. So why do we need to be exercised about the fact that healthcare spending is going up and up and up? Sounds like that's what people want us to spend our money on.
I think they want healthcare, and if it costs money. I think that what they have to do is to be more specific about their needs and understand that you can't just go to the emergency department, even though you don't have a family medicine person. There are nurse practitioners and there are others. It's up to the public now to assist governments to handle this rising cost curve.
But the public is not going to say, please, shut down my hospital. The healthcare system
they
costs too much money.
certainly are not, because they've all come to respect their hospitals, and so they should. But you can provide them with alternatives. And you can't keep expecting hospitals to handle ever-tightening budgets with an ever-increasing demand.
Okay, you've set us up nicely with the word alternatives, because that's why we've invited you all here tonight to talk about some of the alternatives. John Ibbitson wrote this in the Globe and Mail a few months ago, and he sets the table for us as well. An agreement signed between Ottawa and the provinces in 2004 commits Ottawa to annual 6% increases in health funding until the year 2014. Once the deal ends, provinces will be under even greater pressure. There are only 4 ways to handle the problem: divert more funding from other programs such as education, infrastructure, and policing, raise taxes to pay for increased costs, cut back on healthcare services, or permit parallel private care. Rob, here's where we get you in. You run a private surgical center that operates within the Medicare system. What do you do at your place?
What we do is we provide efficient and cost-effective surgeries to the people of Ontario.
What kind of surgeries?
We do hundreds of cataracts, knee arthroscopies, knee procedures, and minor plastic surgery. And we do it at a much more effective and cheaper way than they do at the bigger hospitals.
But you get paid by Medicare, right?
Correct. We are publicly funded just like everybody else. We have a global budget.
So how does being privately owned make it more efficient than if the procedure were done in a hospital or somewhere else?
We have cut the fat. Our administration is low. We have very effective nurses. We work as a team, as they do in the European model of building cars, or Japanese models, where we have everyone working together to get a patient in. We have an incredibly low infection rate and medical mistake rate. and we take great pride in what we do. As you know, 3 years ago, we offered to do hips and knees for the government, which is a very touchy issue. And we can do that at a reduced cost, which means we can also do more cases at our institution.
Is it a volume issue? Is that what makes you better?
It's an efficiency, lack of less waste, minimizing waste. And as Dave will probably tell you, waste is a big part of our problem right now at big hospitals. We also do, as someone else said, skimming. Well, it's important to do those kind of procedures.
What does that mean?
Well, we're choosing, as someone else suggested, we're picking easy cases. Well, that's what Sunnybrook and St. Mike's are for, to do the very difficult cases, the ones where you're doing brain surgery, 10-hour cases, spinal surgery, whereas cataracts and knee scopes shouldn't be taking up an hour or two at St. Mike's or Sunnybrook. You want them to be doing very large, difficult cases where the other cases, such as I mentioned, should be done at institutions such as our own.
So it's cheaper to do it with you.
Correct.
Okay, Jeffrey, over to you now. What do you do?
I think my response to what's just been said is, yes, that is the case, but there's so many others of thousands of cases that don't fit neatly into what you've just said. There are many patients who go to hospitals for care that could be got in an alternative facility where it costs less. The care quality is just the same because they're the same kind of people.
You run one of those alternative facilities?
That's what we're starting to do.
Okay.
And the whole reason for doing that is not because we believe Pembroke Regional is a bad hospital. There aren't bad hospitals. It's a hospital that needs some help. It's supposed to be doing secondary care, having people going to the emergency, and this goes on and on all over the world, going into emergency for something that they don't need to be there for.
So you are providing an alternative location, and so you're not up and running yet, but you will be in the fall,
Next door to the hospital, working cheek by jowl, and working together in partnership. And that's the way I believe of the future of healthcare and to help reduce costs. It's unsustainable. Governments talk about collaboration. We've really got to do it. They talk about integration. We've really got to do it.
We're not doing it yet.
And keep talking about sustainability is a fancy word.
Okay.
The reality of it is to make the change, and that's what we're doing in Pembroke.
Shirley Sharkey, bringing you in at this point. And before I do, full disclosure, my wife is a health policy consultant, and you're one of her clients.
That's
So we
correct.
put that on the table. You run St. Elizabeth's. What do you
Yes.
do?
Everything but a hospital, and location is irrelevant. So we really provide services to people in their home and in the community in a variety of ways, virtually, through online, and direct care. So it really speaks to, Jeffrey, your issue of getting people to access healthcare and information without having to go anywhere, and sometimes without even having someone go into the home. By sometimes a phone call, by the click of a mouse, they can get the information and possibly the care. That's where we could change the cost curve. That's where you could really look at the full episode of care over the cost and getting the best value for people, versus worrying about where they are and how they're receiving the care. It's are they getting the best value for that?
Okay, let me just understand where all of you are, excuse me, on the healthcare continuum. Yours, I presume, is a for-profit operation.
We do have for-profit, but we're publicly funded.
Okay, and yours is what?
Non-profit, charitable.
And as is yours.
Absolutely.
And you're obviously all paid within Medicare.
No, we get certainly government funding. We also have private pay. We have other forms of third-party funding through insurances. So we're in a very interesting space in home and community care.
Well,
where
when you do
people-
home care, you got to bid against others to get the right to provide the service,
Yes, the government work is a very innovative model where you have to compete, which actually accommodates the same issue of doing it well, where quality and performance really are realized. Price can decrease in that environment. You really create services and programs independent of whether you're a for-profit or not-for-profit. The competitive spirit, you have to rise to the occasion to be successful.
Okay.
You're also offloading as well, so you're providing this care in the home instead of going to the hospital or to your facility as well. These are all alternatives that reduce the cost and give viable alternatives.
Okay.
Absolutely. I mean, a recent study showed the economic value of moving people into the community from the acute hospital. So just even starting the acute hospital was hundreds of millions of dollars are saved in that. Now imagine if you change the starting point from the acute hospital to the community and keep them at home longer and keep them functioning in a much more independent way. How you could change that cost curve, because people wouldn't enter the system.
Susan, your company's developed a new technology that dispenses medication out of what looks like an oversized ATM machine. And here I got to do my full disclosure speech again. My wife is, you're a client of my wife's as well. Let the record show, I didn't book either one of you on the program tonight, but I guess, you know, she's in health policy consulting and you guys are doing stuff, so there we go. How does your machine work?
Essentially, we manufacture remote automated pharmacy dispensing systems. And you're right, the machine itself looks a lot like an ATM. It holds over 1,900 different medications with pill counting and refrigeration capability. But the really unique part about our system is that the patient is live video linked to a pharmacist who is in full control of the whole dispensing process and is providing one-on-one counseling service to the patient remotely.
How do you make sure, so you take your prescription that your doctor gives you and
You insert it into the machine,
right?
and that notifies the pharmacist that there is a patient at the med center. The patient picks up the telephone and is watching the pharmacist on the live video link, and the pharmacist initiates the dispensing process. And while the machine is taking care of the more technical aspects of the dispensing process, the pharmacist is freed up to focus on the counseling with the patient, walking them through the medication, any potential drug interactions, allergies, etc.
Okay, consistent with our theme tonight, how does this save the taxpayer any money?
How it saves the taxpayer money is actually in a couple of ways. Number one, it brings health care to where patients need it. So the med center can be placed in communities that currently don't have any pharmacy services. They can be placed in communities where pharmacy services are limited to certain hours. And essentially they expand the breadth of health care, but do it currently within the system and do not cost another penny in terms of pharmacy reimbursement costs.
But that sounds like it's going to cost more money because you're offering more service to more people. Isn't that going to cost taxpayers more?
No, only because patients are being given prescriptions now by their physicians. What this does is it stops the patient from having to travel to a pharmacy, and sometimes they can't do that. They either don't have a vehicle, their community doesn't have a pharmacy, so they're challenged to get access to their pharmacy, to their prescription drugs. And that ultimately, if they don't fill that prescription, that costs the healthcare system more money. In fact, some of the greatest costs within the healthcare system are because patients aren't taking their drugs properly, aren't taking them at all, taking them at the wrong times. What the Med Center does is it brings the pharmacy counseling right to the patient. And that way we can eliminate drug interactions, we can ensure that patients are complying with their medications. And in fact, ultimately, when the system is fully up and functioning, we'll integrate into the electronic medical record and provide the information back to the prescribing physician.
Where are your machines made?
They're made right here in Oakville.
Okay,
Well,
Oakville's down the
Oakville.
road. Okay, I know
Right
what you
here in
mean,
the
though.
GTA.
Okay, I hear. Does the Ontario government like this thing?
I believe they do. In December of 2009, the Ontario government passed Bill 179, which essentially enabled remote dispensing in the province of Ontario.
So are they going in all over the place now?
They will as soon as the regulations that support the legislation are in place. So the Ontario College of Pharmacists was charged with creating those regulations. They have a first draft out, actually it's very timely, just last week, and they'll be posted now for 60 days consultation.
The pharmacists are responsible for allowing you to get this thing in place?
There was-
Doesn't sound like it's in their interest to allow you to get this thing in place.
Well, I think it should be in their interest because really we are a tool for pharmacy. Our med centers enable pharmacists to reach their patients in a more efficient and more effective manner.
Are they stalling? The pharmacists?
No, actually the Ontario College has brought forth the regulations in a relatively timely fashion. And now I think it's our job to really work with them to make sure that the regulations fully enable the technology.
Okay.
And that's the next step.
David, back to you. We're seeing some different examples here of innovative approaches to trying to bend the healthcare cost curve. How much of this goes on in Canada?
Not enough.
How come?
I think that we have a top-down system that really is anti-innovation. Let me give you an example. Most hospitals in the country, certainly here in Ontario, are paid for by a global budget. Doesn't matter if you serve your community well or poorly, doesn't matter if you're innovative or not particularly innovative, you get the same block of cash. Now, as you know, we're talking about moving away from that. Provinces like British Columbia, in fact, are moving away from that. But when you have such a system, you end up with pretty much the same. It's a cookie-cutter model, and we don't innovate enough.
The government talks all the time about innovating, about how it's important to innovate.
Not just this government, in fairness, all of the governments, right?
But they're not putting their, they talk the talk, they don't walk the walk?
Steve, let me ask you a question. Let's
I
throw
thought I did that around here. Okay, go ahead.
As a psychiatrist, I'm allowed to ask questions of anyone I please. It's actually my degree. Look, Steve, as you know, health costs are rising, but let's put some numbers on the table, to use your expression. The Ontario health budget has roughly doubled over the last 10 years. Do you think healthcare is twice as good as it was 10 years ago? No. We pay more. I don't think we're getting value for money. And part of the reason for that is we're not really innovating here. We're talking about innovation, but most of the stuff that gets put forward is actually pablum, putting physicians on salary, that sort of thing. At the margins, not particularly innovative, not particularly thoughtful.
You think there's enough innovation going on,
No,
Rob?
one of the innovations, as I just want to follow up to that, is that with respect to the funding, is one of the thoughts is that the money should follow the patient. So this gives you accountability. So if I am a hospital and I'm doing really well, I have very low mistake rates, high productivity, low waste, well, I'm going to have patients that will come to me, and we should post that. If I can do a knee for $500 and Hospital X down the road does it for $800, well, it's in your better interest to come to us, especially if we're very effective and do a good job. And this way, the funding would also come with that patient, and it will also make our patients in this province responsible for healthcare and the costs. And of course, well, that's just one innovation. We could go on for.
Jeffrey, how much of that information is generally available to patients if they want it?
Not enough. I think if I can take a different tack, business must be concerned about money and bottom line. The healthcare system is being driven by money, and I think this is wrong. We should be looking at what patients' needs are. That's also said, and said so many times, we're looking at patient needs. Well, of course you are. What patients really need is to be well. They want to be able to go and play golf without a hip problem that they've got to wait a year for to get done, whatever it costs. But they need to go to the right place to have it. There are asthmas, there are chemo shots, there are different things that take place in high-class hospitals where they do incredible work, but it's a high cost. Why not move them to a smaller hospital back in their own localities with staff and providers who can travel a bit, and they can do that.
Well, let me follow up with Shirley on that. There is certainly ample evidence that finance ministers across this country, health ministers across this country, first ministers across this country are exercised with the notion of taking that line we showed at the top of the program and bending that healthcare cost curve down. They definitely are focused on that. Where's the evidence that the public is? The public wants their service when they want their service, where they want their service, and they think, as far as I know, that they're getting it for free. So where's the evidence that they care as much about this as people in government do?
Well, there's a lot of evidence that it's really about access to care. There is also evidence that people want to stay at home. And that if you really ask someone, do you want to stay 2 extra days in the hospital or would you like to go home? I think we don't need a whole evaluation review on that. Most people would say, yes, I would like to stay home. The issue is they want to have, I think, a sense of comfort, security, and safety, and then access that they can get the information. But I actually think it's changing. I think the public are more knowledgeable, and if we can provide information to them in a very different way, then it's not about the health system and what that looks like. It's about their understanding of what they need to do, their lifestyle changes, their treatment options. And I think where innovation could take place is not so much the delivery model, yes, that's a given. But I think we could innovate on actually making the public more aware of what not only they need and want, but how in fact we can do that in very different ways.
David, if you would, follow up. Where's the evidence that the public is as exercised about skyrocketing health costs as people in government are?
Well, look, I think people in the public are worrying about their mortgage, worrying about a variety of other things. But I do think that there's a general sense within the public that costs are rising, and a general sense that we can't pay for this forever. And I think it's up to us to offer alternatives. I mean, the public wants a working system, but they don't necessarily want the status quo.
Well, I don't know. Is that a fact? Do you think people, I mean, the one thing the people in this country, I think poll after poll shows that they cherish more than anything is our healthcare system, and ours more than theirs down south.
Well, but that's an artificial poll.
I'd like to comment
Go ahead, Rob.
on that, is that people, I don't think, understand where we are with our healthcare system. We are ranked, and you can help me out with the rankings, but there's numerous ranking systems of healthcare systems in the world. We're ranked 10 years ago, last time the World Health Organization ranks them, was 30th. Can you imagine if our national hockey team was 30th in the world in hockey? We'd be up, or someone fire the coach, get some better players. Our healthcare is 30th in the world. It's ranked 6th on the bottom third by OECD. So if people understand that, they will get up in arms, because we cannot sustain it. Something that is free is not sustainable. If you started handing out TVs outside to watch you for free, how long would you have this show? So sustainability is something that cannot be maintained when something is free like that.
I'm just trying to think through that analogy for a second. I think if they gave out free TVs,
Right.
more people would watch this program, wouldn't
For
they?
how long? Because you go bankrupt.
I'm not sure that analogy works. I'm going to have to think about that for a while.
Well, let's start handing out TVs.
So, why don't you make a contribution on that one? Where's the evidence that the public cares as much about bending that healthcare cost curve as everybody else does?
I think the public only starts to care when they start to get the facts. And I think you had the debate on your show over pharmacy services and how we fund that. And I think if the government hadn't done quite an extensive educational campaign on that particular issue, the public might have felt a little differently about the changes that were being made within healthcare. So I think that the key is understanding the facts and understanding that healthcare isn't free, and that we need to figure out ways to deliver that healthcare, but to do it in a way that maximizes the value for the dollar. And I think as taxpayers, we all agree with that. When we're personally getting healthcare, perhaps we feel differently. We want the best and we want it the fastest. But I think as soon as we educate patients and the public on the cost of healthcare and how we can do it a little bit differently and more effectively, I think they will care, and I think they'll get behind it.
Governments say they're trying hard, Jeffrey, to bend that healthcare cost curve. My question is, are they really?
I think they are. I've dealt with governments in 15 countries, and cost containment isn't new. Their bureaucracies are too heavy to move too quickly. It takes time. I come back to the public needing to understand that it's not a free gift and that they are responsible for their own health. And if we don't start getting that message across, you look at health promotion. The Lalonde report in the 70s talked about putting health promotion in. So governments gave out piles of money to do health promotion. When bucks got tight, that was the first program to cut. So what you're doing is you're actually taking away those primary care and the health aspects of healthcare and not having people involved there. I'm not into trying to turn a cost curve. I'm into what actually makes that cost curve change. And if I'm into that and keep worrying like an accountant on balancing books, I'll never get there.
So your point is we would need to avail ourselves less from this sickness treatment system.
Correct.
If we stayed healthier to begin with.
Be more healthy. How many people are going to come to you and say, I enjoy hospital? You might get a few because they don't have something at home. And the meal in the hospital is better than they get at home. How many people are going to turn around and say, if my hip was better, I could spend more time with my grandchild? And I deal with those people and have done with clients like you. You tell me, I experienced by asking the questions. This has been going on for 30 odd years. The public's getting a little wiser. They sure become wise when they're the ones who have a colonoscopy that proves they've got colon cancer. Then they sure take an interest. And what's their interest? Not cutting the cost curve.
Right.
Make me well.
Exactly. Rob Gordon.
Lifestyle and responsibility for lifestyle, I think, is key. If you want to bend that curve and crack that curve back down, people who smoke, people who don't wear helmets, people who eat sugar and pop and bad foods. And we're not strong enough in this country. We don't have the guts to tell people and make them responsible for their smoking. We all pay for people smoking. 50% of admissions to hospital are smoking and alcohol related. They must be made responsible for that. Exercise, obesity, 1/3 of our children now are obese. That is going to really burden us in the future. We have to make ourselves responsible, just as you said, for that kind of behavior.
Do I see you wanting a comeback on this?
Almost every hospital I visit, and I visit many, have pop cans,
Correct.
potato chips, and whatever in their front lobby. Doesn't seem right to me.
Makes money for the hospital.
Yeah, but it doesn't seem
they
right.
should be
As if there are
taxed.
other ways of making money. And there are other ways of controlling money. Healthcare wouldn't have that there.
David, let me ask you this, because governments talk a good game about trying to bend that healthcare cost curve. But when hospitals start screaming, we've got a deficit because we had a lot of flus this year, and the hospital does a press conference with 3 guys in lab coats, the government picks up the check. So how serious are they about it?
Well, look, at this point in time, I think Ontario has great comfort in running massive deficits. But as you know, Herbert Stein coined one of the most important laws of economics ever when he said, that which cannot go on forever will eventually stop. I think he should have won it. I think he should have won a Nobel Prize for that. But got to serve a president, never got a Nobel Prize. But look, we know this can't go on, and I think right now we're in a phase where we're talking about cost containment here and right across the Western world, and we're not doing very much about it. And what we are doing isn't particularly thoughtful. A lot of wage and price controls, you see, which long-term I don't think is going to do very much. We tried that in the early 1990s, in the mid-1990s. What did we get? Well, we did get cost containment. We got also enormous queues and a lot of dissatisfaction with the system. I think this time around we're going to need to be smarter than that. And just picking up on some of the points my colleagues have made, I think part of that is getting patients more involved in their care, not just in terms of arming them with information, but getting them to open up their wallets. I mean, in Canada, we live in this fantasy world where we say healthcare is free. Of course it's not free. And while I'll recognize that a person who's got cancer and 3 children to support should never have to declare bankruptcy, I also think that we swung to the other extreme where too much is given away. I think if you show up to the emergency department with a runny nose, you should be expected to pay for part of that. I think that if you're wealthy and over the age of 65, you should be expected to pay for your pharmaceuticals. Too much of what we do is based on the thinking of the 60s and the 70s, where medicine was relatively cheap, where we're a prosperous land with a relatively young population.
If I'm right, I think I hear you saying we need 2-tier healthcare in this country.
I'm saying more than that, actually. I'll see you and I'll meet you one.
Go ahead.
Look, I also think we need user fees, and I think we need to think out what ought to be covered and what shouldn't be covered, and to whom. Again, I think some level of means testing and user fees are totally reasonable. Look, if you talk about Sweden, they've been experimenting with user fees for the better part of 20 years.
For what?
For practically everything. You take your kid to the emergency department, you'll have to have a copay involved. Okay?
They do that in Sweden.
In Sweden. You know, that
The
really...
system's different.
Well, of course their system's different. We're not going to find a system like Canada's, but we're going to find points across all of these systems
User fees
where
do
there are
not
things...
work.
Well-
And they don't work in this country.
Okay,
and
stand by on the
shouldn't.
user fee thing. We'll come back to that. Shirley, you wanted to...
I was just going to say, before we throw everything out, there are, maybe the changes aren't fast enough. There are significant improvements that can be made. And I think when you look at just escalation of costs, and you don't put that into what's the value, are we getting better outcomes? Are people satisfied? And what's the cost factor? We know with best practice, for wound care, for example, doing absolutely nothing from who's paying for it, we can improve and reduce the cost by 65%. Wound care accounts for 40% of home care services. That's a small little area. We know that, in fact, if you use an integrated approach with things, you can, in fact, reduce those costs. When we looked at wound care with our program and used technology to have digital photography, the actual time of the visit, the productivity, the recovery, because the client could look at their wound, the compliance, these are just little examples, but they could have enormous change in the value proposition. So I think before we throw the whole thing out and get into that whole conversation.
That's misrepresenting
But wait,
what I
how do
suggested.
you answer-
A user fee is not throwing the whole system
But
out.
before
And
you
not the
go
gates
there-
of hell do not open
But
up.
are you
if you show
suggesting
up
the
with
cost-
with-
One at a time. You made your point,
The gates
David.
of hell do not open up if somebody walks into the emergency department who has a reasonable income, inappropriately using that emergency department, and has to pay part of the cost. Okay? And I would suggest to you that you see cost-sharing experiments right across the Western world which are successful in terms of limiting use and modestly some revenue generation. I think about health savings accounts in the United States. I think about user fees in Sweden. I think that's a reasonable thing to put on the table. What I suggest for a moment for a moment that this is going to resolve our problems? Of course not. We're not going to have one magic bullet here. But I think we need to look to other countries and find things that work.
Let me find out from Rob. Is there a user fee for using your service?
No, there isn't. But what I'd like to elaborate on that as well is I would call it not a parallel, I call it a hybrid system, which not only is used in Sweden, is used in Denmark, Germany, Austria, and all are ranked in the top 10 medical systems in the world. And in our institution, one of the things that is advantageous is we can offload other procedures from the large hospitals, as I said, and do them at our hospital. Workers' compensation is a great one, that if you take workers' compensation patients, put them in our hospital, you've got that much more time in the other hospitals to treat people, and they do that in, as you said, a lot of the westernized countries in the world.
Let me get Susan on this. What role do you think the government needs to play in order to try and make some progress on the issues we're talking about tonight?
Well, building on the example that's just been used, I think the government needs to find ways to provide people access to those consultations and that health care that they need that isn't using up those very expensive healthcare resources, like the emergency room visit. And I think one of the ways to do that is through technology, is to provide things like our Med Center, which provides a live video link to a platform of healthcare providers potentially in the future. So instead of that expensive visit to an emergency room for a runny nose, you can go to a Med Center and be connected to a family physician who can diagnose very easily through that video conference whether in fact you've got something serious enough to warrant a visit somewhere else.
Is that what the public wants to do, though?
I believe they do. I don't think people want to sit and wait in an emergency room for 5 hours to be told, listen, you're fine, go home, drink some soup and call your physician in the next couple of days if you're not better. I think they want to have convenient access to healthcare services. They want to be reassured in some cases. So let's find a way to do that that doesn't cost the healthcare system a bundle. And let's provide patients with that access to the care that they need.
We have that right here.
Jeffrey, what role do you think government should play in this?
I think government should encourage the innovations that are out there.
Are they doing that?
In a way, not much.
Not much, eh?
Partly because their mechanisms are not designed for that. At West Champlain, we've built the Ottawa Valley Health Centre. Its emphasis is on health and healthy community. People can walk in off the street. We'll have technology that helps them understand if their blood pressure, even their glucose, once we get that going, is okay. They don't have to go through a pinprick. Pharma Trust be down in the basement. These are key elements that add, but you've got to help the public understand. You don't have to go to the emergency department.
Okay, less than 2 minutes to go. Shirley, you wanted to say.
I forgot what I was going to say.
In which case, let me try this on for a second. That happens to me sometimes too. But you know what? I usually bluff better.
Well, I was so intrigued with all the technology. I went to the Bahamas for a couple of minutes.
David, try this. If answers are to be found in the privately funded sector, that's a dirty word in a lot of parts of Canada.
Sure.
How do you make that sale?
Well, I think we're private sector phobic. But at the end of the day, I think people want to get care in a timely manner. And I think that if they're waiting for, say, a knee replacement, what they're interested in is getting it in a way that reduces their suffering. As you know, according to the government's own data, I'm drawing on provincial government data, not my data, not Fraser Institute data, none of that right-wing mumbo-jumbo. 7 out of 10 provinces fail to meet the standard that they themselves have set. If we could give people the option between a public provider, fair enough, and a private provider, and they had reasonable information, I think that would be a huge step in the right direction. And by the way, one can find that in Britain, where the Labour government introduced reforms that basically voucherizes certain surgeries, and you have the option of a private for-profit provider as well as other providers. Sounds great to me.
That's the last word today. Can I thank everybody for coming in tonight and participating on this discussion on how to bend the healthcare cost curve. Shirley Sharkey from St. Elizabeth Healthcare, Jeffrey Wetherill, West Champlain Healthy Community Corporation. On the other side of the table, Rob Gordon from Don Mills Surgical, Susan Fenton from Pharma Trust, David Greatzer, Manhattan Institute, and the book is The Cure, How Capitalism Can Save American Healthcare. Thanks, everybody.